So, something I often notice among my friends and other working professionals is this that they struggle with excruciating period pain and try to brush that aside by saying that this is normal, everybody goes through this, I can deal with this. And having known some of them personally and over the years, I have seen them struggle with this like almost forever, and that has made me think that is this level of pain really normal, or could this be a sign of a greater problem like a disease like endometriosis. And I'm sure that like me, many of us would be having this question, and to find answers to my questions I have Dr. Shujata Datta. She's a renowned gynecologist and laparoscopic surgeon with Fortis Healthcare. Welcome to the show, and thank you for taking time out to be with us.
Thank you, Vishakha. Thank you for having me here. I'm very pleased that we're having this conversation because, as you say, there are many women with endometriosis who live silently with their pain without realizing that there are solutions to it. So, we would try to solve some of those problems for them and give them directives as to how best to deal with the problem.
Amazing. And that brings me to my first question, which is what exactly is endometriosis?
So, endometriosis is a condition where the lining of the womb can be present outside the womb. It can be present on the ovaries, it can be present on the surface of the uterus, on the ligaments behind the uterus, in the wall of the pelvis, and in fact, a lot of other organs of the body can have these endometriotic cells. What happens then is just as you have your periods every month and it comes out as bleeding, there is bleeding in the other parts of the body where there is this ectopic tissue. But there is no route for it to escape, and therefore it accumulates there, causes irritation inside, inflammation, which then leads to fibrosis, which is scarring inside. And that is what causes the pain and other complications of endometriosis.
Okay. Um, that also brings me back to the first topic that I touched upon, and that is many women experience painful periods. When does the period pain become a red flag?
Period pain, some people have period pain right from the start, but it's usually mild and it's usually addressed or gets better with simple analgesia like paracetamol. But if you have period pain which is not improving with simple paracetamol, or you continue to have it throughout the cycle no matter what you do, that is a red flag, and that could be a sign of endometriosis, and you need to get investigated for it.
Okay. And what are the symptoms that a woman should never ignore when it comes to endometriosis?
So the main symptom is pain. It can be severe pain, it can be throughout the cycle, there can be pain outside of the period days as well. But there are some accompanying signs and symptoms which would also raise the suspicion of endometriosis. And those are pain during intercourse, pain while opening your bowels, pain during passing urine. All of these can be a sign of underlying endometriosis.
And as you speak about the symptoms, it does come across that it affects many spheres of our lives. So, my next question is but I would want the answer from you. So, can endometriosis affect fertility and the overall quality of life?
Definitely affects the quality of life. If you're in constant pain, it would interfere with your day-to-day activities, and it's something that you have to then, you're trying to plan your life around pain, and that's not what you should have to do, because there are solutions, there are ways to solve the problems. Some women do have problems with fertility, and often this is one of the things that people come to us with, inability to get pregnant. I'd say about 40% of women with endometriosis in some form can have issues with fertility, and the sooner it's looked at and addressed, the better. The reason why fertility can be affected is because it's been shown that the egg follicles in ovaries that are affected with endometriosis are not that good of a quality. And as we get older, we're all born with a basket of eggs, but as we grow older, we start losing some of these eggs each cycle. And it's been seen that if you have endometriosis, then the rate of attrition of these eggs is quicker. So you lose eggs faster, the quality of eggs deteriorate. Then there's fibrosis, there's inflammation. The tube and the ovary could get stuck because of that, and so the tube is then unable to capture the egg and pass it on to the uterus. There's also the environment. The pelvic environment is hostile because of all these chemical reactions that can happen as a result of blood, which is an irritant, and because of endometriosis and some abnormal cells called macrophages that can be present in the fluid of the pelvis. So all of these mechanisms contribute to fertility not being that good in some women with endometriosis.
Yeah. And as you speak, what goes on in my mind is diagnosis is very important. So, how do we diagnose endometriosis? Are scans enough to detect that we have this disorder?
So, as with most things, when we see any patient who comes to us with a history of period pain, we ask them a set of questions which would cover all the symptoms that we've already talked about. We then do a physical examination, and just by a good physical examination, we can often get an idea of who might have endometriosis. Because of the scarring from endo, when you do an internal examination, you can feel hard nodules, scar tissue, which are tender on touching just behind the uterus. You can find cysts that can be palpable. If they're big enough, they can be palpable when you do a physical examination. So all of these physical examinations would give you an idea of perhaps endometriosis is the problem. We would then do an ultrasound scan, which has to be done by a specialized doctor who sort of has had special training in looking for endometriosis. Because whereas it's quite easy to pick up the large cysts on ultrasound, sometimes the scarring, the lack of mobility between organs, where the bowel comes and gets stuck, or the ureter is sort of strangulated because of endometriosis, cannot be picked up by a simple scan by somebody who is not looking for it. So there are specific ways of doing an internal scan. It's called a transvaginal ultrasound. But what is really the gold standard, I would say, and easy to pick up all endometriosis is doing an MRI of the pelvis, because that shows up even the scarring and the endometriosis that is not always easy to pick up on ultrasounds. So this is really the flow. And then finally, there are some things that cannot be picked up on MRIs either. Early disease such as peritoneal disease, where the lining of the wall has blebs of endometriosis, but you can't really see it well because this is prior to the fibrosis and the scarring setting in. And for those women, we do laparoscopies, which is we put a camera through the belly button. It's like an endoscopy of the pelvis, and we can see what's going on and take biopsies from those spots to confirm endometriosis. This was a very common practice when I was in training, but now we've moved away more and more from doing laparoscopy for diagnostic purposes, because the imaging has generally become so good that we like to plan ahead and we see and treat. So we would not just do a diagnosis and come out. If we found endometriosis, we would treat it at the same time, and that's a much better way of planning or dealing with endometriosis.
Wow, so many new things to learn. It's eye-opening, and this is why it's essential to speak to a specialist, because what we do is hear somebody has endometriosis, immediately Google, look up a few things that scare us off and shut it down thinking, oh, let's not go to a specialist. That brings me to my next question. What treatment options are currently available? And the other question would be, are lifestyle changes in any of these cases of endometriosis enough to solve this problem or control the disorder?
Yes, that's a very good question. Now, how we treat patients depends on a lot of things. It's a lot of factors that you have to take into account. First is the age of the patient, how bad the symptoms are, fertility plans for the patient, what you're seeing on scan. Um, all of these would help us decide what the best available treatment is for a particular person, and one size doesn't fit all. So it has to be tailored to that particular person in their area of at that time of life, let's say. So generally, there are two ways of managing it. One is with medical therapy, and one is with surgical therapy. Medical therapy is obviously the first line because we want to give you medicines to suppress the bleeding completely or suppress your periods completely. And you wouldn't have periods for a finite amount of time that you discuss with your doctor and decide on. If you don't have your periods, similarly, the bleeding that goes on inside at the time of periods would also stop. And so, if there's accumulation of blood in cysts that have formed in the pelvis, it's likely that over a period of time, the blood would get resolved. And so, the symptoms would get better. So, medical therapy is mainly for symptom relief. It doesn't actually cure the problem, because even if that blood that's sort of accumulated there gets absorbed, the area from which the bleeding is happening, the lining of the womb that I told you about, the ectopic lining, is still going to be there. And so the moment you come off the medicines, there is a quick rebound of symptoms because the same thing starts happening again, and blood accumulates again, and fibrosis and inflammation, and it's a vicious cycle that then goes on. So it's good for symptomatic relief, doesn't completely cure the problem. And of course, if you are planning fertility, if you're planning a child, then you can't be on medical therapy, because if you suppress ovulation, if you suppress periods, that means you're suppressing ovulation and you can't get pregnant. So then we have to think of surgical therapy. So what we do depends a lot on, as I said, what the symptoms are, what we find on the scan, what the fertility plans are, and the age of the person. Because there are ways of even surgically treating the patient without removing the uterus, because there's a thought in the mind that if I go for a surgery, it means we're going to have the uterus removed, the ovaries removed, I'm never going to be able to get pregnant again, there'll be a hormone imbalance because I'll get hot flushes. Not always true, because what we do now more and more is uterus preserving surgery and fertility preserving surgery, especially in women who are young and may want a family later. So we remove all the diseased tissues from everywhere, but we try to conserve the healthy tissue, as in the healthy uterus and the healthy ovary and the ovaries that are healthy, that part. But of course, we have to have a discussion before, because we need to sort of discuss what the chances of recurrence are if we don't remove all of this. Now, definitive surgery, which means removal of the uterus and ovaries and all the diseased tissue, can be done and is usually done at a later age, in their late 40s, or people who are suffering from severe symptoms, have had surgery once and still not gotten better, or there's recurrence. That with definitive surgery, the chance of recurrence is a lot less. So all of these factors have to be discussed before a plan of surgery is decided on with the patient.
Okay, I have a follow-up question to that. Let's say person X is somewhere in her early 30s, no immediate plans of fertility, and we are going with the symptom suppression procedure that you just explained to us. What I'm trying to understand here is the end goal for, even if we go that way initially, is the end goal a surgical procedure, or can it be continued long term, considering that this, I'm sure it will vary from this person's case, and you have to consider other factors. But just I'm trying to understand that even if you go with suppression of symptoms initially, is surgery the end goal that we are looking at always?
So initially, as I said, initially symptom relief is the main thing. Asymptomatic, we may not have to do anything
Okay.
great. If they're asymptomatic, they're having a laparoscopy for some other reason, and you find a little bleb of endometriosis, which the patient didn't know about, was completely asymptomatic. We don't necessarily have to, treat it. We would just keep an eye on it and observe. However, if the patient is symptomatic, if there is pain, then the first line is always medical therapy, or in most cases medical therapy, unless fertility is an issue, around the corner. But some people will not have adequate pain relief, and the disease might progress. Although the symptoms are suppressed, there are some, not everybody will have progressive disease, but there are some women in which the disease might progress. For instance, obstructive symptoms. If you get constipation, bloating, unable to open your bowels properly because the disease has spread to the bowel and is slowly increasing and causing a stricture there, or similarly affecting the urinary tract, and you get hydronephrosis, and the pipe that brings urine from the kidney into the bladder gets affected and gets closed off, and then they're at risk of losing the kidney. So those are symptoms or signs where we have to operate no matter what, if you have obstructive symptoms. Fertility and pain. So pain is the main symptom for which we would operate, together with fertility. Pain and fertility we would operate on. And as I said, then the rest, there's never a one solution for everybody. You have to see what problem you're dealing with, how severe the problem is. Is it getting better with medical therapy, or do we need to go to the next step, which is surgery?
Yeah. Now, only if you're comfortable and without naming anyone, of course, what are one or two case examples that you would like to highlight where you have felt that, like, oh no, early detection could have not led to this stage of the disease?
Yeah.
If you would want to share one or two
Yeah.
such instances.
I just wanted to mention two patients who have recently seen, and one is to tell you about this young girl who was about 31 who came into my clinic, and she'd been having period pain for a long time. She'd had scans and nothing showed up, but she continued to have pain. She had lots of medicines from different doctors, didn't get better. So we did an MRI, and sure enough, there was endometriosis in a lot of pelvic areas. So when I gave her the report and said, look, we now know what it is, it's endometriosis. And the only thing she said to me was 11 years. So then she said that she had been living with this pain for 11 years. And she just thought, I've kind of wasted those 11 years. I could have perhaps known about this earlier and dealt with it better if I'd known what I was dealing with. So that's just to show that the average time that women live with pain before going to a doctor or having a diagnosis is anything between 8 and 15 years. And there are a lot of teenagers, young girls, who have pain, and they're just told to normalize that pain. Oh, everybody has period pain, just deal with it and don't be a sissy. And that's not true. Period pain is not normal. So if they have pain, they really should be seeing a specialist to get to the bottom of it. And the second story I'm going to tell is a lady I've just operated on yesterday. It was a long surgery, but this is a lady who'd been having period pain since 2018, had been on medication, empiric, so it wasn't diagnosed. But then she was just dealing with it, having painkillers. Then she went to a general physician who did an ultrasound. And the ultrasound showed hydronephrosis and hydroureter, which is swelling of the kidneys and the ureter, which is the pipe that brings urine into the bladder. And that's when she was referred by the urologist to me. Again, an MRI showed severe endometriosis, which is strangulating the bottom of both the ureters. So she was at risk of losing both her kidneys, which would be a life threatening situation. So, only because it was diagnosed in such a roundabout way and having gone through the loop for so many years since 2018 was she diagnosed, and we immediately had to bring her in for surgery. We excised all the abnormal tissue, all the tissue that was encasing the lower ureter like a stricture, like a stranglehold, and we have to cut away all the fibrotic and diseased tissues. Medical therapy does not help here because you actually have to remove the obstruction. And it was a long surgery, but she's very well now and will soon be going home. So,
Wow. It gave me goosebumps when you were saying 11 years, this girl, she was struggling with the
yeah.
pain. Uh, but before we close, what is one message that you would like every woman to hear about endometriosis?
Yeah, I just want everyone to know that endometriosis is a very, very common disease. It's an illness that can affect girls and women across all age groups. And in fact, even postmenopausal ladies can have endometriosis. Don't suffer in silence. Please see a doctor, get the right investigations done, because there's a solution to every problem that will help you lead your life in a more comfortable way.
Thank you. Conversations like this are really important because the faster the diagnosis, better the treatment, and also women feeling heard. And to everyone watching, if your pain feels severe, disruptive, or consistent, we would insist that you see a specialist as soon as possible and not normalize pain. Thank you.
Thank you very much.